Thank you very much, and it's delightful to be in hot Georgia, although I must say that Iowa is also around 100 degrees right now and dry, so I haven't left home, gone far. For those of you who were at the Iowa meeting, I can tell you that clinical knowledge about FSHD has not changed dramatically, so you will see some overlap with what I said back then. So the goals of my talk are sort of to set the stage for the rest of the speakers. I'm going to provide an overview of clinical aspects of FSHD. I realize everybody in the room knows somebody with FSHD and probably knows more about it in a lot of ways than I do. But there are probably some in the room who are recently diagnosed and are still learning about it, so I'm going to give you that overview. I'm going to talk a little bit about some rare variants, summarize management, and recent publications. And then after yesterday, I'm going to throw in a couple of editorial slides that are just clarification based on yesterday, unrelated to the clinical stuff. So FSHD is the second most common adult muscular dystrophy, prevalence of somewhere between 15,000 and 2,000 or 20,000, 1 in 15,000 to 20,000, and we're hoping to learn a little bit more about that over the next few years, and I'll mention that later. It affects males and females in equal numbers. It's an autosomal dominant disease, which means that with each pregnancy to an affected individual, there's a 50-50 chance that their children will also be affected. So with each pregnancy, the next one doesn't know what happened in the previous one. So with each pregnancy, it's 50-50. And about 20% of FSHD cases are thought to be caused by a new mutation. So in other words, nobody else in the family has it. As clinicians, we like to organize things because it helps us remember things. FSHD fits into, there are lots of ways to organize the muscular dystrophies. FSHD fits into the autosomal dominance. There are a lot of other autosomal dominant muscular dystrophies and then other types too. So this is just sort of where you fit in one organization system for the muscular dystrophies. So you heard a lot yesterday about the current molecular advances in FSHD, and I just thought it would be helpful to review where we've been. So 1886 was when this was first described and known, and I'm reviewing here the clinical genetics of this disease. So in 1886, autosomal dominant inheritance was first reported. About 100 years later, it was mapped to the long end of chromosome 4, and that's what we've been talking about since then. And I think a theme of what I'm going to say here is that there is an accelerating knowledge. 2 years later, the deletion that we now know is at the basis of FSHD was first described. About 4 years after that, DNA-based testing became practical, and that DNA-based testing, while it has continued to evolve and improve, has allowed us to learn a lot more about the variants and the cases that aren't the typical classical ones that were described back in 1886. And then in 2009, the genetic basis for FSHD2 was reported, and that has also allowed us better insight into the molecular basis of the disease, the basic science of the disease. So, so it's been about 20 years since the original mutation was identified, and I think in that, if you think about, it was 100 years from identification of the inheritance to finding where the disease resided in the human genome. And in the last 20 years, I think we've made a huge amount of progress in understanding this disease, and I think the next 20 years are going to be very exciting. This is just for review, FSH1 versus FSHD2, because I mentioned it. Remember, this was done several times yesterday. So FSHD1 is a length-dependent loss of methylation. FSHD2 is a non-length-dependent loss of methylation. There is another genetic little variant thing in that some people in their blood, rather than just having the deletion or just having no deletion, have a mixed population. So they have some cells that have the deletion and some cells that don't have the deletion. That's called a somatic mosaic. If you are a somatic mosaic, you may or may not be affected, sort of depending on the percentage of cells in any tissue that might be affected that have the deletion, and probably your genetic background. Overall, these are old studies, but they say that if at, say, 50% mosaicism, a male is more likely to have symptoms than the females. And those who are mosaic tend to be more mildly affected. So probably a few of our new mutations are people who actually inherited the disease from a parent who was a mosaic but didn't know that they had the disease. So I wanted to mention I'm going to talk about it a couple times in the talk, the National Registry for Myotonic Dystrophy and FSHD, or colloquially called the Rochester Registry because I can't say all those other words. And they recently reported sort of a quick summary of what they've got as of 2012. They've been collecting data since 2002, and I think probably many of you in this room have contributed data. This is voluntary, it's online, you can do it, from the comfort of your own home, and it's something that everybody can do. There's no cost, there's no downside. There are 572 people enrolled with FSHD, and of those, 59% have genetic confirmation. If you aren't enrolled, I'd encourage you to enroll. The other thing I wanted to mention now is that I said that we're going to be learning a lot more about the epidemiology, I think, in the next 3 years, I wish. The CDC has just started a program built on an existing surveillance program for Duchenne muscular dystrophy. It's being expanded now to include all muscular dystrophies, including FSHD. So we're collecting a very, very small amount of data. We're not going to be, it will by no means replace the Rochester Registry, but it will give us population-based information about how many people out there carry a clinical diagnosis of FSHD with the best of our ability to find them all. This is not something that you can volunteer for. It's not something that you need to do anything about. There are trained abstractors who will be going to medical records with various kinds of permissions in different states and identifying people, but you will be seeing data from this in the next 3 years. So FSHD usually starts in late teens or adulthood. Sometimes people will say they've had mild facial weakness since childhood. Grandparents often tell me that I can tell that which of my grandchildren are going to have it because the ones who had it slept with the whites of their eyes open a little bit. So they'd go in and look at them in the crib and the whites of the eyes were showing, and those are the ones that were going to grow up and have FSHD more obviously when they were older. Classically, about 95% of affected people will have weakness if they are examined by an experienced observer by age 20. The Rochester Registry, the mean reported age at onset of symptoms was 21. So that's fairly consistent, that you may have some subtle findings an experienced examiner can identify before you report onset of symptoms. It's really important to note that there's a huge degree of variability that can be seen even within a family, and many of you in this room know that. Some family members may be more severely affected, some less severely affected, and that speaks again to the fact that there are modifiers, genetic and environment, that we do not yet understand about this disease. FSHD2, I said the ability to diagnose FSHD2 is a relatively recent thing. There was a recent report looking at the clinical features just of FSHD2. They looked at 33 individuals. The age at onset was 26, so a little bit older than most reported average ages of onset for FSHD1. The pattern of weakness was identical to FSHD1, but they do note that that could be because that's how we know to look for FSHD2. If you don't look like you have FSHD2, we don't look for it, so it makes complete sense that they look identical. The genetics was interesting in that the genetics appears to be quite different. So there are only about a third of these cases were familial, and they could be either recessive or dominant, and about 2/3 had no family history of FSHD. So about 2/3 rather than 10 to 20% were new mutations. I'm a pediatrician. I see adults and children, but I do have to talk a little bit more about kids. So the early onset or I use early onset FSHD rather than infantile onset FSHD, but they're the same concept. In the 1970s and 1980s, there were these single case reports of, I saw this person who looked like they had FSHD, and then they also had this severe retinal vascular disease of the eye called Coates disease, or I saw this person who has FSHD and also had hearing loss. And it wasn't clear for a long time whether these were one thing or two things. And in 1991, it was demonstrated because we now had the ability to do genetic testing, that these early onset cases with eye disease and hearing loss were the same molecularly as those with typical adult onset FSHD. So we aren't talking about two diseases, we're talking about one disease with different manifestations. And there is a general relationship, not 100%, but there is a general relationship between the size of the deletion and the severity of disease. So that if you have a very large deletion or a very small residual fragment, you are more likely to have early onset and more severe disease associated with retinal and hearing loss. And I would point out that in this paper, I don't know whether you can read it there, but this top line is males, the bottom line is females. So in this paper too, males tended to be affected a little bit more severely than women, and that's been a sort of a theme over the years, that maybe there's a sex effect in there somehow. So I mentioned earlier, 10 to 20% have early onset disease. The residual ECO-R1 fragment is generally less than 20. And of over 500, this is several years ago, samples tested that were abnormal at the University of Iowa, about 10% had very large deletions with ECO fragments less than 15. So somewhere between 10 and 20% will have this more severe disease. The pattern of progression, again, you guys know this, facial muscles and scapular winging and anterior tibialis. So the first things that are typically affected are your ability to smile, ability to close your eyes tightly, ability to get your arms over your head, and the ability to walk on your heels. Now, of those, the ability to walk on your heels is the least noticeable because most adults don't go around trying to walk on their heels unless they come to my clinic where they all have to walk on their heels. And then you can have involvement of the muscles on the front of the chest. The abdominal muscles are affected early. Again, if you're not doing sit-ups, that may not be something that you notice. And then the muscles at the top of the arms. Another thing that's very typical about FSHD that is unusual in the muscular dystrophies as a whole is that the one side is not the same as the other. Most neuromuscular diseases were pretty symmetric. FSHD is almost unique in that it is a typical and standard part of the disease that there's often marked asymmetry. So a relatively new presenting syndrome for FSHD is one that affects adults, and this photograph is taken from one of the publications. These people have mild or minimal facial weakness, but they have this bent spine, and that is how they present, with this bent spine and spine weakness. Wheelchair use, overall, classically, about 20% of individuals are in a wheelchair full-time by age 50. Now, we have more recent information from the Rochester Registry where 30% of that 500 to 600 people reported that they used some sort of power mobility anytime, long distances or short distances, and about 20% of you are in a wheelchair full-time or some sort of power mobility full-time. So the old data is holding up with the Rochester Registry. I'm going to mention this briefly. Shri Panja is going to be talking more in detail about the physical therapy aspects of FSHD later. There are very few papers specifically addressing FSHD and exercise. This is one of them. In none of the papers is there evidence that exercise is harmful to muscle. Now, you can hurt your joints, you can become more fatigued, there are a lot of other things, but there's no evidence that it's harmful to muscle weak evidence that it might be helpful, and this is just one of those papers. They looked at 8 FSHD patients. They had 12 weeks of standardized training, and this was with a bicycle. This was done in Denmark, where everybody bicycles. And most reported improved strength, endurance, and level activity, and the black bars say are for improved after this 12 weeks compared to baseline. Chronic fatigue and pain, these are huge problems with FSHD. I don't probably need to mention that to this room. 50 to 80% of patients with FSHD report chronic pain, most often back pain. In my clinic, it's often neck and shoulder. Much more than the comparison in the Rochester Registry, again, much more than a comparison group with myotonic dystrophy, another dominant disease. It correlated with the need for mobility. Really nothing was dramatically helpful. In this paper, heat was helpful to some. Again, in my own experience, I think the major thing is quit doing the thing that makes you have pain. And for some people, that means, say, okay, I'm going to use a scooter at work to get from point A to point B and decrease my walking, or I'm going to have somebody from HR come down and do an ergonomic assessment and figure out how to get my arm up higher so I'm not dragging on my shoulders. Pain is very difficult to manage in this disease. We do all the standard things, again, heat, and a real good ergonomic assessment and figure out what hurts and try to quit doing it. This can be helpful. So the hyperlordosis is that C shape to the back, and it's related to weakness of the trunk muscles. You can't fix it by doing sit-ups, so we don't ask you to try. In some cases, an abdominal corset is helpful. I have patients who are in a wheelchair with an abdominal corset, and they say that they are much more comfortable with the corset on than without. People who are extremely mobile find that they don't like the corsets because it really limits your ability to bend and move and things like that. So it's something, there's not a downside. You're not going to do harm, and it's something that some people find helpful, and it's a relatively cheap and easy thing to do, and I don't know whether Shri might be talking about that more. Both of us have the picture from John Kissel at Ohio State. We have these great people who agreed to pose for these pictures, and we're not going to reproduce the wheel. Scapular fixation, many of you have considered that or talked to your clinicians about scapular fixation. Why do you consider scapular fixation? The primary indication for scapular fixation, because it is big surgery, and this is basically wiring the scapula or the, what's the other word for it? Shoulder blade, thank you. Wiring the shoulder blades down to the ribs. It is not trivial surgery. The primary indication is that people who have preserved strength elsewhere, if you have that done, you will maybe be able to do things like wash your hair, fix your hair, put away dishes. So improved function, you have to really think, if you're thinking about doing this, you really need to think about what you want to get out of it. Improved function is probably the strongest indication for doing it. It does make you not do this, but do this. So some people want it for cosmetics. It's big surgery for cosmetics. Think about that one very carefully. The improvement in function will last only as long as the other muscles that you're using work. So you will have progressive loss of strength, and you may lose that increase in function, but you will gain time. And maybe it decreases shoulder pain. At the same time, if you have marginal respiratory function, it will probably decrease your respiratory function by up to 10%. So again, big surgery, maybe some respiratory issues. You need to think about it very carefully, and you need to make sure that you work with an experienced surgeon in this disease. Facial weakness, problems that the facial weakness causes include dysarthria, difficulty making your speech understood, and then dysphagia, difficulty swallowing, and then unrelated to the dysphagia or difficulty swallowing, but another problem that people report is the fact that they're uncomfortable eating in public because they sometimes have trouble keeping food in their mouth, and it's a social problem often for young children. Working with speech pathologists with experience can be helpful. Respiratory issue, I mentioned it a little bit with the scapular fixation, but respiratory compromise affects about 1% of the Dutch FSHD population. Risk factors were wheelchair dependence, significant spine deformity, and chest wall deformity. We are having a talk later today just on the respiratory issues, so I'm not going to discuss that at great length, but to tell you that we do have management for respiratory issues. If it's identified, we have management, so we need to monitor. Cardiac involvement, you know that many forms of muscular dystrophy, the heart is involved. You guys are lucky. That's probably not an issue because that one's a tough one to treat. Depending on how hard you look, you know, we're doctors, we do better and better tests, and we can find problems in almost anybody if we look hard enough. And in fact, that is true in FSHD. If you look hard enough and do fancy enough tests, you can find some subtle abnormalities. The rhythm disturbance is what most people have found. However, that is almost never, virtually rarely, clinically significant. In other words, it doesn't do anything to you. It's a test result, but it doesn't do anything to you. You don't have problems with your heart. And so the consensus guidelines right now say that we do not recommend routine screening. I honestly routinely do an EKG intermittently, but that's cheap, it's easy, it doesn't hurt. But there is no routine screening needed, and you don't need to worry about that one. Hearing loss. Patients with early onset FSHD often have hearing loss, which can require hearing aids. In general, with EcoR1 fragments of less than 17, and that hearing loss appears to be progressive, so make sure that you have repeated testing. If you had a normal newborn screen and you have infantile or early onset FSHD, you're not done. You should have hearing tested again. Once you get into sort of upper school age and you're able to say, I can't hear the teacher, then you probably don't need to have it done anymore, but the young children should have their hearing tested. Those of you with typical onset or late adolescent and adult onset FSHD, the bulk of the data says that the hearing loss is not different than the general population. Yes, some of you have hearing loss, some of you require hearing aids, some of you listen to very loud rock bands when you were younger. You have hearing loss just like everybody else who listened to very loud rock bands when you were younger. So those with typical onset FSHD don't need any special screening. The eye disease, the patients with early onset FSHD can have Coates disease, which is a severe abnormality of the retinal vessels that can, if untreated, can lead to detachment and blindness. There are a number of studies that have looked at large populations. Up to 75% may have some degree of retinal vessel abnormality. And then recently, there have been some adult patients who've been reported to have Coates disease. So the bottom line here is that we're recommending that everybody have at least one dilated retinal exam by somebody who is aware of the fact that FSHD can be associated with retinal vascular abnormalities. So at diagnosis, we recommend that you have an exam. You don't need to have serial exams unless there's a problem. And this picture shows that the arteries here are too wiggly in this eye. And that's the retinal vasculopathy. This is a mild degree. This is not likely to be associated with a problem, but the ophthalmologist will follow this child. And there's some evidence that the severity of the retinal disease correlates with the severity of the disease. Okay, another controversial one. Anybody who has worked with a lot of people with FSHD knows that many of you are extremely bright, and we don't look at the brain, we don't worry about the brain at all. On the other hand, there are a number of papers. This series, this Japanese series that I have up there is probably the only series, but a number of case reports and some instances in families where epilepsy or mental retardation tracked with FSHD in a family. So and then there are some laboratory tests, some MRI studies, and some electrophysiology studies that again suggest maybe there is some brain involvement. Again, There is zero evidence that for most of you there is anything wrong with your brains. There's no dementia. This is not a brain disorder. On the other hand, it appears that in the most severely affected children, and this is maybe more of interest from a science standpoint, maybe there is some abnormality. This DUX4 is doing something in the brain in early development too. So it's controversial. There's some, where there's a lot of smoke, maybe there's something there. Pregnancy and FSHD. This is again a study done by Emma Schiffeloni using the Rochester Registry, and maybe some of you participated. So there was a survey of 38 women who between them had 38 women who between them had 78 babies. About half knew of the diagnosis at the time of the pregnancy, which is consistent with the fact that they were self-reported only mild to moderate disease. So this is at one end of the spectrum of FSHD. Overall, there were good outcomes. They said that they would have another child. They wouldn't hesitate to do that. The obstetricians weren't worried. However, there was an increased incidence of forceps deliveries and C-sections relative to the national norms at the time. And about 24% reported an increase in weakness that did not get worse or did not improve once they had the baby. So about a quarter of them reported that the disease progressed. And interestingly, there was an increased number of low birth weight babies in this group relative to the national norms, and we don't know the explanation for that. Management, there was a workshop held in the Netherlands in 2010 to develop a consensus statement. So this is not a you must do this, but this is a consensus statement, a bunch of people sitting around a table and saying, well, this is what I think we ought to do to manage. So I'm just going to fly through sort of guidelines on management, but this is available to your physicians if they have questions about what they're supposed to be doing. Genetic education and counseling, it's an autosomal dominant disease. Hearing evaluation on all very young patients and as clinically indicated later in life. A dilated retinal exam at diagnosis. Monitor respiratory function, particularly if there are risk factors or symptoms. Speech therapy if there's a problem and try to find an experienced speech therapist. Physical therapy, which will be one of the next talks. Exercise, moderate exercise may be beneficial. Cardiac evaluation, probably not. And psychosocial support is critical, and that's one of the things that this society does for us. Speaking of this society, for those of you who haven't seen it, the society recently supported publication of this guide for the schools, which is for individuals, not just the most severely affected, but anybody who's in the school system through college. And many of you helped contribute information to this. So you might take a look at it. Even if you are in the workplace, you might flip through it, pick one up, because there might be some ideas that you can use. Psychosocial support, the MDA was mentioned yesterday. These are pictures from this year's MDA camp. The little girl in the middle, she lives for her week at MDA camp. What's her diagnosis? FSHD. So remember that the MDA does a lot of things that help people in addition to just funding research, and MDA camp is one of those, and it's a huge thing for kids with neuromuscular disease. Okay, now I'm going to add two more just quick editorial comments. One is there was a discussion yesterday of the funding of scientific investigation. Remember that, and I review grants for NIH, MDA, and FSHD. So all are very valuable institutions and all fund good research. NIH funds disease or research related to health and disease, and they try to do the best science in all diseases. MDA is strictly related to neuromuscular diseases, all neuromuscular diseases. FSHD Society, though, is just to FSHD. And FSHD Society does a fabulous job of encouraging and supporting new investigators or established investigators who are new to the area. You can't get funding from the MDA or the NIH unless you have some preliminary data. You have to be able to create a story that what you're doing is worth supporting. The little dollar signs there reflect the usual sizes of the grants. The FSHD Society is critical for getting that preliminary data to go on to one of those other organizations to get more money. But they do sort of different things, and they work together. There is synergy there. And I also just wanted to mention that the research that's being done in other diseases may help you. For example, somebody talked yesterday about short hairpin or siRNA as possible means of treating FSHD or certainly studying mechanisms. That work builds on the virus work that was done to try to deliver dystrophin to boys with Duchenne. Without that virus work that was done on Duchenne, we would not be able to start casually talking about delivering siRNA to cells with FSHD. So there's a lot of synergy in science, and you have to remember that. You fight for your disease, you contribute to the FSH Society, but remember the fact that another disease is being funded doesn't mean that you won't potentially benefit. Being able to treat one neuromuscular disease is going to be huge for the entire field. So with that end of that editorial comment, I'd like to thank Dan, Nancy, and the many families who've educated me over the many years about FSHD and the FSHD Society. Thank you.